Good morning, and thank you again for joining our webinar, Building on CalAIM's Housing Supports. We will first hear from Dama Diaz, Health Equity Fellow, working with the Advancing People-Centered Care team at the California Healthcare Foundation.
Thanks, Sharon. Well, hello, everybody. Good morning. Thank you so much for having me here today. Like Sharon said, my name is Dama Diaz. I'm a Health Equity Fellow at the California Healthcare Foundation, working at the intersection of homelessness and healthcare. So I wanted to give you a brief introduction of who we are. The California Healthcare Foundation is an independent nonprofit philanthropy that works to improve the healthcare system so that all Californians have the care they need. We focus especially on making sure that the system works for Californians with low incomes and for communities who have traditionally faced the greatest barriers to care, such as people experiencing homelessness. If you're not familiar with us, you can learn more about us on our website, chcf.org. And I have to say that we're just very, very honored to have supported this work with the Corporation for Supportive Housing. So with that, thank you for having me, and I'll pass it back to Sharon.
Thanks so much, Dama. I'm Sharon Report. I'm Director of California State Policy with Corporation for Supportive Housing. CSH is a national nonprofit and community development financial institution. We work to advance solutions that use housing as a platform for services to improve the lives of marginalized populations, particularly for people experiencing homelessness. And I'm going to turn it back over to Dama to talk about the policy brief that just came out or just became published yesterday.
Yes, thanks, Sharon. So before I dive into the paper and describing it, I wanted to note some of the context. We know that while the healthcare system cannot by itself solve homelessness, we do also know that it does have a crucial role to play in providing access to services that are critical to people who are unhoused. Too often, people face substantial barriers to meaningful care. And that's the connection between, this work that CHCF has supported CSH in doing, this homelessness and healthcare intersection. So this brief examines the successes, challenges, and the opportunities in providing person-centered care to people experiencing homelessness, and CSH cites substantial research throughout the brief. So we know that every fact is well documented. The first part of the brief outlines in detail how homelessness undermines a person's health. When people live outdoors or without reliable shelter, existing health issues are made worse, and people develop new ones. At the same time, they face significant barriers to accessing care in a deeply fragmented healthcare system. And that's why it's so important to remember that the primary driver of homelessness is the lack of affordable housing. And the next part of the brief describes opportunities in CalAIM, the two other initiatives to fund housing support services and connect people to housing. The section also explains CalAIM's enhanced care management benefit and the optional community supports. And yet implementation of these programs is challenging. And the brief then outlines how providers and managed care are faring so far. The final section of the brief is devoted to solutions. And that's where we want to focus on today. So I'll turn it over to Sharon now to move us into a discussion of those ideas.
Yeah, thank you again, Dalma, for CHCF's critical role in co-authoring and publishing the policy brief. And on today's webinar, that's where we're going to focus, is on the brief, and specifically on 4 of the 7 policy recommendations that Dalma mentioned. So let me introduce the presenters for today's webinar. Cheryl Winter is the Associate Director for California Policy, also from CSH. Cheryl is a licensed clinical social worker and has experience both providing services to people experiencing homelessness, as well as offering technical assistance to providers. Glenn Hilton is the Director of Community Care at People Assisting the Homeless, or PATH, and leads implementation of CalAIM funded housing services in San Diego for PATH. Janai Moorhead is a consultant with the Foundation Consultants. As a person with lived experience of homelessness, Janai also offers expertise in Medi-Cal funded housing support services and advises service providers in the Inland Empire on contracting with managed care plans. Jeanette Rodriguez is the Housing Services Director with the Office of Homeless Care and Coordination within the Alameda County Healthcare Services Agency. She oversees CalAIM funded housing support services in the county. And Linda Way is the Associate Director of Policy Advocacy on the health team at Western Center on Law and Poverty. Linda leads Western Center state health policy work around homelessness. And I will be moderating today's session as well. So as Dalma mentioned on today's webinar, we're going to start with an overview of services people experiencing homelessness need to gain health stability. And then we'll follow that with a discussion of challenges and solutions by delving into 4 of the 7 policy recommendations in the policy brief. We'll have 2 brief Q&A sessions during the discussion of the solutions and a longer Q&A session at the end. I just encourage everybody to write your questions into the Q&A box on the bottom of your screen. And feel free to do that at any time during the presentations. We'll go ahead and get started. So first, we're going to have an overview from Cheryl and Glenn, who will talk about the health needs of people experiencing homelessness and identify housing support services that CalAIM funds.
Great. Thank you, Sharon, for that introduction. As Sharon said, I'm going to kick us off by speaking about the health and service needs of people experiencing homelessness. And I want to draw your attention to the screen, specifically to the left side of those arrows. Here you can read about some of the common health needs and common realities faced by people experiencing homelessness. The experience of trauma, being forced to focus on your own survival, negative experiences and discrimination in traditional healthcare settings that leads to distrust of healthcare and providers, the experience of your body aging more quickly while living on the street and worsening physical and mental health symptoms, which then leads to earlier mortality, dying younger than your peers who haven't experienced homelessness. And on the right side of those arrows, I want to draw your attention to the service delivery design and approaches that we must include when we're creating new service packages and rates to go along with those packages. Because we need to ensure that we are engaging people experiencing homelessness and the providers closest to them in the design to be sure that we are promoting health, building trust, breaking down barriers, and putting people at the center of their care. So speaking of barriers, on this slide at the bottom, you'll see 2 different system designs. On the left side, you'll see all sorts of different service systems, housing systems, support services, primary care, behavioral health. And pay attention to that orange and gray arrows. Those are barriers that are blocking an enrollee that has the experience of homelessness from accessing those systems of care. And some of the barriers we see are as simple as not having a home address to put on an application in order to get access to some of those systems of care, or not having bus fare or a ride with someone you know and trust to be able to make it to an appointment on time, or not having an ID to be able to apply for certain benefits that you are entitled to, but maybe your bag was stolen at the shelter you stayed at last night, or your encampment was plowed down and you lost everything recently. But those are barriers that keep people experiencing homelessness from accessing that traditional service system. And then on the right-hand side, I want to draw your attention to what looks like a bit simpler, less crowded system of care, but it's actually more time consuming and complicated to design. And so that's what we'll be talking about today. It's a person-centered system of care, and it's one where we have to listen and revise and refine our approaches to design considerations in a way that includes people's needs and removes those barriers. So it's about how we design the forms that are created and the assessments that we give, and how people are authorized for services, and how we engage people in outreach. So we have the evidence, the research, we've had focus groups, and we know what it takes to provide these services. It's multidisciplinary teams. It's spending time in outreach and engaging people where they're at, meeting them on the street, in shelters and encampments, helping them to get to appointments. And it means designing services and ensuring that service providers can hire people with lived experience and people who are closest to the communities that are disproportionately experiencing homelessness. So these are the transformative ways that we need to be providing services and structuring our service design and approaches to address those health needs and social needs of people experiencing homelessness. With that, I'm going to pass it on to Glenn, who will talk us through a bit more about CalAIM.
Great. Thank you so much, Cheryl. What's really exciting is that now we have the opportunity to use Medicaid funding to provide services like the ones that Cheryl's talking about related to housing for people experiencing homelessness. Although Medicaid does not pay for housing in the form of rental assistance, there are several ways that Medicaid does support people and helping them find housing and stabilize in their housing situation. So first, there is some funding available to pay for homeless outreach workers to go into the streets and the communities, meet people who experience homelessness, build rapport and trust, kind of to the point that Cheryl made about the difficulty that we have in engaging people in those services, provide resources, and eventually engage them in housing-related and case management services. For those that are ready to find housing, Medicaid funds housing navigation services, where case managers and housing specialists provide the supports needed to help them move from homelessness into housing. This often includes supports to obtain required documentation, increase employment or benefits, income, identify healthcare, mental health or substance use services that they are needing and ready for, and address community connections. We also help with locating affordable housing units and qualifying them for possible subsidized housing. While people experience homelessness, they typically lose all or most of their personal possessions. So Medicaid-funded housing deposits provide the upfront funding from those moving into housing solutions, excuse me, to cover such costs as security deposits, furniture, appliances, and other essentials or modifications that would make their empty space into a livable home. And then going back up to the center of the slide, once they're housed, many people will need additional supports to help them adjust to and stabilize in their new living situation. Without these supports, many new residents would struggle to retain their housing and likely would return to homelessness. Medicaid provides funding for these ongoing supports in the form of tenancy sustaining services. So this slide kind of gives an image of the two main components of CalAIM. And since I keep using that abbreviation, there's your explanation of what it is. California is advancing and innovating Medi-Cal, which for the rest of this presentation will only refer to as CalAIM. It started in early 2022, and it's a significant program reform effort that addresses a variety of benefits and services that coordinate the medical and social service needs of individuals while addressing their social drivers of health. CalAIM's categorized into two distinct categories of benefits and services, which are designed to work together to address the specialized needs of the high-risk and underserved populations that Cheryl spoke about just a few minutes ago. Each of these benefits and services are delivered by community providers who receive Medi-Cal funding for the services they provide from the managed care plan that provides that client's Medicaid insurance coverage. So the first component is what's called enhanced care management. This is a benefit for people with complex conditions. There are a number of specific populations of focus, and people experiencing homelessness make up one of those population groups. They also generally fall into several other populations of focus because of complex medical needs and other medical needs that they have. Because enhanced care management is a benefit, any Medi-Cal member that qualifies is entitled to receive enhanced care management. And that includes having a designated lead care manager that works collaboratively with all of the healthcare and non-healthcare providers to coordinate their care. Kind of taking us back to the images that Cheryl shared a few minutes ago, rather than having a whole bunch of little pots to deal with, really helps keep everything organized and tidy and make sure that everybody is actually integrating our care. In addition to enhanced care management, CalAIM authorizes and encourages managed care plans to offer a variety of community support services, each addressing a particular situation tied to social drivers of health. Community supports are expected to be medically appropriate for the plan member and more cost-effective than traditional solutions. So, for example, moving an individual into housing is expected to reduce their medical costs of emergency department visits and hospitalizations and things along those lines.
Great, thank you, Glenn.
We'll
Have
now,
a bit more.
Oh, you have one more. I'm sorry.
Just going to drill down on this last one. So regarding the community supports, there are 14 different community supports available. The 3 that are listed here are the ones I've already referenced briefly, but these are the ones that we're really referring to as the housing related community supports. Okay, all yours.
Thank you. I apologize for that. I'm anxious to get to solutions, it sounds like. We are now going to outline the first solution that is outlined in the brief, which is creating a Medi-Cal benefit. But first, I'm going to hand it over to Janai to outline a few of the challenges from the current context.
All right, there we go. All right. Thank you so much for inviting me on this webinar. And I appreciate the fact that you asked me to have some input. My name is Janai Moorhead with Foundation Consultants, and I'm also an educator in the UC system, and also proud mother and grandmother. Grandmother is the fun part. But I say that because I have lived experience, and my lived experience has helped me to appreciate both sides of the homeless provider and also being homeless. And when I was in my catastrophe or crisis, one of the things that I look forward to is to make some or suggest some significant changes as to how homeless persons or families can be helped better, and also to be a better homeless provider. While I was thinking about this, I also had a family. I was working, and I had 6 children with me. And so that was a daunting task to move forward and get out of the crisis, but here I am, and I'm very appreciative of all of the people who helped me. So my talk today is challenges for the homeless service providers, which I am. And I just want to briefly talk about the 3 before me. The first one is multiple managed care plans for providers to navigate, all with different culture and language than the community-based providers. Now, I want you to understand that I am, or many of us are working with the managed care providers. And from experience, okay, I have learned that we definitely have different professional language that is interchangeable. And one of the ways I work through my managed care plan is to ask questions. And I appreciate that the managed care plan provider did answer them. And one day we had a conversation and we asked each other, are we saying the same thing? And we both said, yes, we're saying the same thing, we're just using different language. So we did slow down, talk to each other, and explain that when I say this, I mean this, and the managed care provider did the same for me. That way we were all on the same page. So, but that is a little bit of a frustration with the homeless providers and the managed care providers. And many of the nonprofits that I work with have let me know. And so I shared with them my simple solution. The managed care provider, one of my managed care providers and I have agreed to do one amazing thing, which is send emails back and forth and say, let's talk. And I think that that's extremely important, because so many times the managed care provider and the homeless provider are just emailing, but our managed care provider was nice enough to say, hey, get off the email and let's pick up the phone and let's have a conversation so that we can get to the root of the situation that we're both trying to solve. The second thing in the slide is that homeless service providers have limited capacity to build Medi-Cal with small and BIPOC-led providers experiencing the greatest challenge. And that is so true, so true. As we started with the contract with our managed care provider, we immediately understood that we would have to build our capacity even greater, even though we worked to build capacity up until the point to get the contract, which we were very appreciative and happy to get. However, there is more funding needed, and that funding involves personnel, and it definitely involves equipment. And so there's limited upfront funding to enter contracts with delays, and there's always a lot of delays and hurdles to access grants and technical assistance. So that leads me, well, let me stay on track and then I'll go down to the grant funding. But the next point is the providers may spend significant time with a client and never get reimbursement, which is true. So we found out that when we get an authorization from an MCP, we go into nonprofit mode. And when we go into that mode, what happens is that if we cannot find a client, then we start searching for that client. We go into street outreach mode. And some contracts with MCPs may not pay for the homeless providers to do outreach. They do pay for the service, the housing navigation, the tenancy and the housing deposits, as Glenn previously talked about. But when we spend significant time trying to bring that client up to the point of getting into housing, we may not get correctly reimbursed. And so this is one of the questions that I ask our managed care plan in searching for the client. Do we get reimbursed? And then we were told, no, you don't. But however, I did receive excellent advice. And now we are using the street outreach teams to help us to find our authorized clients that the MCP has given us. And then they can help the client on the street get a hold of us. And then the third point is that grant-funded providers typically use functions very different than the Medi-Cal reimbursement, which is true. It is outlined in the slide. We write the grant, then we get the award, we go do the work, and then we write the report to the funder. But it is totally different when you get to work with an MCP, and many times the MCP now gives the provider the information in a portal, and then you read what you can offer or what is authorized to do. You provide you try to contact the individual, and then you work with them usually through housing navigation first to get them up to speed and ready for housing. Okay. And then all of this happens prior to you billing. Okay. And then you bill. So those are some of the challenges for homeless service providers. And I'll turn it back over to the next speaker.
Good afternoon. So building upon what Janai was referencing in terms of challenges, I'll speak to the pieces related to efforts in referrals, authorizations, and reauthorizations, and challenges we've encountered in that realm. So operationally, we've encountered challenges when working with multiple managed care plans. So many communities have multiple managed care plans in their community. Operationally, what we work within is trying to track, monitor, ensure timely reauthorizations and requests for authorizations, and really navigating within these complex new billing requirements, as well as the frequency of the billing and claiming cadence. Within those complex billing requirements too, it requires then a whole personnel and a whole team of dedicated staff members that are adept at reading, tracking, monitoring, billing related claims, which is new for our community. Additional challenges that we have seen and encountered as well is when individuals are shifting between managed care plan affiliations, which then requires a shift in terms of authorizations or reauthorizations, demonstration of different documentation. We know that managed care plans then may require different documentation, may also authorize provision of housing community supports with differing term limits and also differing processes for backup documentation for those requests. In terms of, as what Janai had mentioned previously too, there's challenges with staff service providers when there's outreach efforts and engagement efforts in which there's funding constraints or there's not reimbursement related to those efforts. The individuals that we're providing services to or connecting to provide services to may need additional encounters, periods of time to really build a relationship and a connection before then they're proceeding to receive housing navigation or tenancy sustaining services. In terms of managed care plans, interpretations of different guidance and deposit assistance or tenancy sustaining services, there's variations that we've seen then from the service provider perspective, and then variations in terms of what demonstration of accompanying documentation is needed. That's also then impacts the community's service providers in the frequency of what information is needed, how it needs to be produced and extracted from the multiple database systems. The last two items there to reference the racial disparities in terms of referrals for individuals. And also the managed care plans are not currently aligning referrals with existing housing and homelessness systems of care and the prioritization process. I think it's Linda. Thank you.
Thanks, Jeanette. Janai and Jeanette did a great job sharing the challenges of the current healthcare system for people experiencing homelessness and providers. So now we'll offer a solution that is currently working its way through the legislature. Assembly Bill 1085, authored by Assemblymember Mainshine, builds upon the investments to homelessness through health dollars by creating a pathway for housing support services to be a Medi-Cal benefit. The bill requires the Department of Healthcare Services to seek federal approval to make housing support services a Medi-Cal benefit. Under CalAIM, Medi-Cal plans may offer a range of housing support services to people experiencing or at risk of homelessness. As a plan option, this results in variations across counties and even within the same county. This makes access to services inconsistent, inequitable, and difficult to administer. A benefit would reduce variation by setting a standard eligibility criteria applied statewide and eliminate additional constraints Medi-Cal plans may apply that Jeanette mentioned, such as time limits. A benefit would also address equity concerns. Under CalAIM, eligibility for services is largely based on determinations around the healthcare costs an individual has incurred. Considering the historical inequities in the health system that results in disparities in not only health outcomes, but also access to service for Black, Indigenous, people of color communities, this perpetuates inequities and significantly narrows people receiving housing support services. We know that far few people receive CalAIM services than receive services under the whole person care pilot. And again, that bill number is AB 1085. And so the whole person care pilot came before CalAIM. Although the number of people receiving CalAIM services is growing, our legal aid partners continue to report challenges accessing services. As an entitlement, a Medi-Cal benefit, more people will access housing support services, are no longer subject to plan-specific eligibility criteria or long waits that's often driven by provider capacity constraints. A benefit allows housing support service providers to access a stable, sustainable source of funding more easily, helping build provider capacity. And finally, a benefit would also open the doors to significant federal funds that the state is currently leaving on the table. With up to a 90% federal financial participation rate, meaning the federal government will cover up to 90% of the cost of housing support services, California can tap into significant federal funds. We already know that this approach of making housing support services a benefit is effective in 20 other states. That includes red states like Arizona, Louisiana, North Dakota, as well as Washington, to name a few. A benefit is especially timely when you consider the rise in homelessness and those experiencing homelessness with a disability. The Department of Healthcare Services has shared its intent to make all community support services a benefit, with housing support services being the farthest along, since it is offered by all plans in all counties. AB 1085 would establish a timeline to move forward with this goal. So now I'll pass it back to Sharon, who will open it up for brief questions.
Thanks so much, Linda, Janai, and Jeanette. That was really helpful. And we are going to take our first questions. If you haven't yet, please feel free to write your questions in the Q&A tab at the bottom of your screen. And I think so far we do have a couple of questions. Somebody asked if we could repeat the bill number. Linda, do you want to do that?
Yes. Again, the bill number is AB 1085 by Assembly Member Mainshine.
Thank you very much. We do have a question around, do you have an example of a homeless service provider that has limited capacity to bill Medi-Cal?
I'm happy to tackle that and then if others want to chime in.
Great, thank you, Cheryl.
Yes, Eric, we have many examples. What we're seeing is that moving from traditional homeless services to the administrative task that it takes to track people's authorizations, start dates and end dates, complete all the paperwork to submit the claims to be paid. It means for the average frontline staff worker moving from about 90% of their time in the field, meaning working directly face-to-face with people, to about 70% of their time, because then they are using about 25 to 30% of their time completing that paperwork. For administrative staff, it means hiring additional people to help you track those start and end authorizations, and as Janai mentioned, new databases and financial management systems and staff to help who have experience in tracking and submitting claims. And so it really does it has presented a challenge for many homeless service providers. And I've recently completed technical assistance with 39 different agencies across the state. And that was one of the biggest challenges, was really this capacity to not only start up, but then hire and retain staff, and the shift in your already existing staff in all of those operations that were new.
Thank you, Cheryl. The next question is, are people able to be referred to an MCP, managed care plan, for enhanced care management community supports from other sources, or is it completely driven by the authorized list from the MCP? And I did notice one of the other participants did respond that for the most part, as long as someone is enrolled in Medi-Cal and connected to a managed care plan, anyone can refer to enhanced care management or community supports using that managed care plan's referral process. And then the managed care plan will determine if they're eligible for ECM or CS. Glenn, did you want to add to that?
Yeah, I will just say that for some health plans, if a member already has an enhanced care management lead care manager, the health plan will require that referrals go through them as opposed to being submitted from third-party providers.
Thank you very much.
May I add?
Yes, absolutely.
I did find that we could do that. Originally, it was just we received the authorizations from our MCP, and we did attempt what we call, in the homeless world, we call it a reverse referral. And so that's a referral back to the managed care plan, and they did accept it. And so it does work. We had to fax it in, but it worked just perfectly. So that's possible, yes.
Thank you, Janai. We have a comment from Greg Rodriguez from Riverside County. We have at least 30 providers in Riverside County that don't have the capacity to bill for community supports. And I wonder if, Jeanette, if you just want to take a minute and maybe mention Alameda County's role for those providers who don't have capacity.
Sure. Alameda County implemented a process in which we serve as the intermediary between the two managed care plans and service providers. And currently we then subcontract out to 19 different service providers and provide the housing navigation, tenancy sustaining services, and housing deposits throughout the county. So in that intermediary role, then the county is able to then handle and process billing and claiming authorizations related to the managed care plans, and the service providers then are providing the direct services and are really the subject matter experts in serving individuals.
Thank you, Jeanette. There's a question for you, Linda, from Kevin. What advocacy can be taken to support AB 1085? Are MCPs supporting?
Great question. As mentioned, it is in the legislative process currently on Senate appropriation. And so that appropriations tends to be where a lot of good bills die. And so making sure that it gets out of the appropriations process and moves forward. Senator Portantino is the chair of Appropriations Committee. So encourage making phone calls to or writing letters to Senator Portantino, as well as leadership such as Senator the Pro Tem Atkins. The Medi-Cal plans have not come out in official support of the bill, but we have had positive conversations with them. And so they have said that they are supportive of expanding it to a benefit because they recognize that there are challenges as a community support. And so are supportive of the concept of moving it forward as a benefit.
Thank you very much, Linda. And I think we'll move on, but we will have, I know we have multiple other questions in the queue from both the chat and the Q&A tabs. And so we will get to those questions in our next question and answer session. But for now, I want to make sure we get to the content too. So we're going to move on to the discussion of challenges and solutions around rates. And so we're going to have today Glenn and Cheryl talking about some of the challenges and the solution number 2 around adequate rates. Glenn?
Sure. Thank you, Sharon. So as Janai mentioned briefly, providers need to separately negotiate contracts with each of the managed care plans that we plan to serve. To share a bit of our particular experience as an example, when CalAIM first started, there were 7 managed care plans operating in San Diego County. So we had to negotiate and contract with each one individually. PATH reached agreement to contract with 6 of those health plans in San Diego alone, and other ones in other counties. And each health plan agreed to different rates of pay and sometimes different payment units. So for example, some agreed to a flat per member per month payment rate, while others pay a separate fee for each client encounter, not paying for the additional efforts made to connect with members who are harder to reach or to locate. Although we had completed a robust cost analysis to run the program before we began negotiations, few of the health plans agreed to fully fund the staffing levels that we knew we needed so that we could provide the essential care for the higher needs population that we served. We were not successful at getting agreement to receive higher rates for higher acuity clients, for example, who required sometimes far more staff time in order to achieve their program goals. The rate guidance provided by the Department of Healthcare Services and implemented by many of the health plans do not adequately address the indirect costs needed to prop up these robust services that ensure a high standard of quality care. There are incentive dollars to provide some of those front-end supports, but those are short-term temporary funding. And obviously, to run a program, we have to be able to have funding that is sustainable. The chart that you see here shows a comparison between the commonly contracted managed care plan rates currently being paid for CalAIM housing services against those rates that are being recommended by other independent models that have been studied. And as you can see, there's quite a disparity between the flat rate of $300 to $450 per month that we're seeing from many of the managed care plans versus what is being recommended in terms of working with even the less intensive clients in some of the studied models. I'll just mention here also that the Commonwealth Fund is anticipating the release of a ROI calculator to the public next month, and suggests that any interested organizations may want to take a look at that when it comes out, particularly if you're planning to begin to implement something similar to CalAIM housing programs. To add to the challenges that we see, providers across the country are also experiencing significant challenges in hiring qualified staff. Everybody is having that challenge, obviously, but that means that we're recognizing the need to increase wages substantially. And at the funded levels, many frontline staff right now are making wages so low that they themselves qualify for the services that they're providing to others. And that's obviously not something that we're very content with. So the wage increases that are being put into place to recruit good quality staff are likely to only exacerbate the funding deficiencies that are inherent in the current funding levels. So Cheryl, what are some of the solutions being proposed to address some of these challenges?
Well, thanks, Glenn. I appreciate you mentioning that ROI calculator that the Commonwealth Fund is going to be releasing. I think it's very new for homeless service providers to have to think about negotiating rates, and definitely on a per person served basis. So what we are proposing that is a solution is to pay adequate rates for housing support services, and that those adequate rates must include those ongoing costs that are new staffing costs and new ongoing costs related to technology and user licenses, that is required for being contracted with managed care plans and now being a provider within the healthcare system. We know, as Lynn said, that the homeless service workforce has been underpaid and that homeless service providers face an extremely difficult time in hiring and retaining frontline staff. The work is meaningful, very meaningful, but it brings with it vicarious trauma of seeing people that you grow close to suffering and dying. It's a regular occurrence. It means exposure to elements, exposure to violence, and similar to what we see emergency room staff and hospice nursing staff encounter, it means working with individuals who face some of the most serious illnesses and chronic conditions and who are the most marginalized in society. So it's not minimum wage work. And it also requires that we are true to the evidence base and the research of what we know works, which are these smaller service provider staff to client ratios of 1 to 10 and 1 to 15. What we're seeing right now with rates that are being offered are 1 to 30, sometimes 1 to 50 ratios. And at best, when coupled with other funding, you might be able to get to a 1 to 20 or 1 to 25 ratio, which is double that of what the evidence base shows when we're working with people that are experiencing, multiple challenges, chronic health conditions, serious mental illness, active substance use, and many other marginalizing features. So in order to meet the evidence-based staffing and service structures I talked about earlier, we need to also acknowledge that we need livable wages. We need to be looking at actuarial models and finance staffing models that account for those multidisciplinary teams and those small caseload sizes. It's not an easy conversation to talk about rates, but it's a necessary one. All right, next we're going to dive into solution number 3, which is using the homeless service system to refer people to services. And Glenn, I'll hand it over to you.
I think on this one, Janai is the one who's going to be.
Oh, I'm sorry, Janai.
Oh, that's all right. Thank you so much. So this slide is challenges for managed care plans, and it's very important. All of these points are extremely important, and I have been talking about them for a long time. But the first one is the managed care plans having difficulty knowing which members are homeless or at risk of homeless or leading to lagging referrals. So this is where the homeless providers shine and can assist the managed care plans in understanding some of the tools that homeless providers use in determining who's homeless, who's at risk of homeless, and how to apply maybe prevention or diversion. So I'm always advocating and have explained to many people that there are standard tools that many homeless providers use at our office or in San Bernardino County and maybe in LA County. There's a federal form that we use, and we fondly call it the Exhibit E. And the Exhibit E is a federal form, so it may be nationally used, but just called different things. And it's widely used over many platforms. It's just that the name changes for the program. But that's a guide that pretty much everyone uses to ask questions and figure out what category people are in, literally homeless, at risk, and so forth and so on. And then it also asks for verification or what happened. Asks for what happened from the client in their words. And then there's also a space for the caseworker to say what they are seeing and how did they verify that person is homeless. And it gives room for the caseworker to verify homelessness personally or use an outreach worker to verify that. So these tools are guides. They're guides for providers to use. And I think if managed care plans would adopt these tools, then we can be on a uniform basis to figure out can help, whether, and where that person, are they on the street? Are they couch surfing? So forth and so on. Okay. The next one talks about plans. The plans use different sources of data to find people, requiring providers to navigate referral pathways. So data is really important, and this is where I always push the homeless management information system, and I have advocated for the MCPs to become users of the homeless management information system. It's really important. This would do for MCPs what it does for homeless providers. It allows us to input the client into an information system and then share the data with the the providers that are in that system. And what that does is it allows us to figure out who's helping them and how we can best help them also. And then also it prevents duplication of services. And this is something that I have heard from MCPs. Today, it is literally possible for an MCP in their community supports division to give a person a housing or community supports, and then for them to contact us and for us to do the same thing, and we'll never know. We'll never know, okay? And so this system prevents duplication, and then there will be more funding for other homeless people. So that's something that that I would love to see the MCPs using the homeless management information system, not only as a data collection, but actually having people to input the information so that they can report to other providers, hey, we're helping this person. And then the other providers can say, okay, if you're helping with housing, then we can help with something else. Okay. And then the last point is that it's very important to understand that connection to services does not mean people will get connected to housing providers. Okay. Providers must connect people to systems that refer people directly to housing. We recently we are working with the MCP, and they had questions as to why does it take so long to get people into housing. And so we developed a workflow to let that MCP understand what it takes, from beginning to end, what it takes to have a person to get into housing that is literally homeless. And thankfully, that workflow was very easy for them to understand. And they wrote us back saying, thank you so much. That is extremely enlightening. But it really does take, like the slide says, it can take 9 to 12 months before moving. It really does. And so that's the points that I wanted to make. And I'd like to hand it over to Jeanette now.
Thanks, Janai. So building off of the recommendations and solutions related to the homeless management information system, I'll talk a little bit about how we implemented in Alameda County. As I referenced earlier, we implemented our housing community supports as healthcare services serving as an intermediary role with the managed care plans and the community-based organizations and service providers. We began our housing community supports program in January 1, 2022, hit the ground running from our whole person care transition. And what has been really helpful in terms of solutions and streamlining is that we, as part of our subcontracting with 19 organizations, we implemented the use of our homeless management information system and our community health record to build upon and utilize our coordinated entry process and coordinated entry prioritization and referral system for referring to housing community supports. So to date, we have served over 2,000 individuals collectively throughout our community, and continue to increase that number. As I mentioned earlier, then we currently work with 19 community organizations. Part of the implementation too, and utilizing our existing database systems, is to really utilize existing prioritization processes within our community of care, using our coordinated entry system that allows us to align and increase access to individuals that we know have the greatest barriers to receiving care. And then our coordinated entry system is also person-focused. It's a person-focused system, and that really supports and ensures that there's an equitable and consistent process in our community. We prioritize people who are most in need of assistance, as well as strategically allocate current resources and identify the need for additional resources. As I mentioned earlier, and as Janai mentioned, building upon existing database systems, the Homeless Management Information System, service providers have familiarity with that system. We are able to look as a community to reflect the number of individuals who are currently homeless in our community as well. We utilize our community health record too for database matching and resource sharing. For our community, as I referenced earlier, we have 2 managed care plans that we work with in utilizing our coordinated entry system and referral and prioritization process. What we were able then to do is really utilize a dedicated referral pathway and tracking mechanism. We use our HMIS system to really report on returns on investments, returns to our homeless system of care. If individuals are exiting and retaining housing, what that percentage is, what percentage of individuals are returning back to a homeless situation. Within Alameda County, what we've also implemented is a somewhat unique model in that we leverage other funding resources to ensure continuity of care for those who are not eligible or are currently working towards eligibility with a managed care plan. The benefits of this process is that we're able to allocate resources in our community and also to really ensure that there's a clear, transparent, and timely communication stream that exists. As Janai mentioned, our HMIS system, we're able to then see who's providing the services, who's in communication with this individual, at what point of the service integration model is the individual receiving services. Within Alameda County, what we utilize is our permanent supportive housing pool, or housing queue, for referrals to housing navigation and connections to housing navigation. As Glenn mentioned earlier, the housing navigation process is really key too, in terms of gathering documents, applying and searching for housing and moving in. And related to what Janai said, there's a long period of time in which it could be 9 to 12 months in which somebody is then receiving housing navigation before they're then connected to a permanent housing resource. The benefits in this solution of working with an existing homeless system of care resources is that we're building upon existing systems that have a large breadth of data and information and a familiarity already with the service providers. And I will turn this back to Sharon.
Okay, thank you, Janai and Jeanette. That was really helpful. Let's take another few minutes to answer questions. And we've had quite a few questions coming in, so really appreciate everybody participating in the webinar and asking questions. One question that I did want to turn over to Linda is what sort of solutions are being developed that address the challenge of how service providers are paid after the fact for their services? Does AB 1085 address this issue?
Sorry, I think the question was if AB 1085 addresses provider funding, correct?
Right. Yes, it's really around right now, providers often get reimbursed for services that they've already provided. And that makes it really difficult for them to be able to pay for their staff up front. So I think the question is getting at, does the bill or creating a benefit address that issue of managed care plans basically paying for services after they've been delivered?
Great question. And the bill provides the stability that unlike with community supports, it is it is for the next 5 years. And so as a benefit, it is not something that it provides that stability that it's not there. It doesn't necessarily provide funding to a guarantee to providers upfront funding. I will mention that there are existing incentive programs that plans have been provided through that should also streamline down to providers, although we know that there are that not all that money has been spent that has been provided there, as well as additional incentive funding through the PATH program to help, as well as other funding, startup funding for capacity building. But I think other providers can speak more to the challenges there. But the bill does not specifically require provider funding be provided up front, but does provide a guarantee that if a provider provides that service, it will be paid for.
Thank you, Linda. And just to add to that, I do think that generally for benefits, just like with ECM, we do see that managed care plans do typically get more funding in their capitated rates to provide services that are offered through the benefit. And so that's an ongoing source of funding, and so can make it easier for managed care plans to pay up front too, if that's the way the benefit is designed. We also got a question. Are you saying that clients who need more care do not get more care or got shafted because some managed care plans are not paying more? I don't know if somebody wants to take that.
I'll take that because I think that's a response to some of what was said a little bit earlier also. Just from the standpoint of the providers, I would not say that the participants are being shafted or failing to get the care they need. Even in those months when we lose the ability to continue to be funded to provide services to clients, we generally do not immediately exit those clients because we believe very strongly in continuity of care. So what ends up happening in order to do this work is that providers are having to recognize that we will lose funding and that we will still have to find a way to safely transition those members to a funding source that is acceptable and allowable. And in the meantime, we will be providing free services. For those that require a higher level of care, what it does is it forces us to do the best that we're able to do to get a good mix of lower acuity and higher acuity clients on our caseload. So we do generally find that, because we were a whole person care provider previously, we have fairly high acuity clients on average. And so we end up having to try to seek lower staff client ratios so that we are able to be able to provide the level of supports that are needed.
Thank you very much, Glenn, for that answer. There is a question that I think Cheryl answered in the Q&A, but Barry asks that he's interested in learning whether any counties or which counties or networks are investing in establishing community hubs as a billing credentialing support for CBOs that want to work with CalAIM funded services. Cheryl, do you want to respond to that a little bit more?
Sure, yeah, this is, has developed in some counties where either a county department, like Jeanette's, is taking the lead on being that hub, and then subcontracting to a network of providers who then are not having to bear the administrative burden of all of the invoicing and claims and quality assurance that's related to that. But we are also seeing some of the homeless continuums of care expressing interest in being that hub, or other networks of care. It really varies depending on which county, because in some counties, managed care plans have said that they will not contract to an entity that will then subcontract to others, where in other counties that is being that is happening already and has been going on for some time. So there's a lot of variance right now in the structure for community supports and how it's implemented and how contracts are made and who is going into contract. But I agree with you that there is a need for that, and we are seeing entities express interest in being that sort of hub.
Thank you very much. And so the last question I'll just take right now, and please keep the questions coming, is from Angela, who's already doing CalAIM community supports, and the biggest challenge they're seeing is lack of housing. So that kind of feeds into our last topic this morning, which is aligning services with housing. And I'm going to turn it over to Glenn and Jeanette to talk about some of the challenges that they are seeing in doing so.
Great. Thank you, Sharon. And thanks for that question. Yeah, it probably isn't news to anyone on the call that housing markets in California are extremely tight. In San Diego, for example, the average cost of a one-bedroom rental is $2,400 a month, which is far more than the total income of a lot of our residents. We can't get to where we can pay more than 100% of our income for rent. That's just not doable. So we also have fewer available units than the total number of people already known to be experiencing homelessness in our area. So if we had a direct pathway to housing right now, we would still have people experiencing homelessness. And it sort of creates a sort of a human shell game where the most vulnerable are often the ones that are losing out and not getting the housing that they need. And a recent report showed that in San Diego, for every 10 households that we help get into housing, 13 more are entering homelessness. So we're losing ground rather than making ground in spite of all of the good work that's happening. So creating new housing is a critical component to the pathway toward ending homelessness in California, and it just simply isn't happening quickly enough in the current environment. Building new affordable housing and supportive housing that includes ongoing intensive care management supports for those who need them requires compiling a patchwork of funded sources, planning and implementation cycles that necessitate long-term funding commitments of at least 15 years. In the current political climate, much of the funding provided is done in more of a patchwork fashion with much shorter commitments of support. Because Medicaid does not fund ongoing rental assistance, the burden therefore is currently on CalAIM enrollees and their families, supported by their housing providers, to fund, locate, secure, and maintain housing within the members' budgets. For some of our clients, this means they're spending 85 to 90% or more of their income on rent, dramatically increasing the likelihood that they will return to homelessness at the slightest financial setback. So to resolve these challenges, it's going to be important for greater collaboration between the public and private sectors to commit to funding for new housing construction or rehabilitation and repurposing, and developing expedited pathways to completing and leasing up these projects with incredible speed and efficiency. This is going to require long-term commitments of support at the federal, state, and local levels. Another important element of moving us forward will be the increased collaboration between DHCS, the health plans and the providers. And the new Community Supports Policy Guide published last month by DHCS does strongly encourage health plans to work with providers to explore ways to advance pre-authorizations of CalAIM benefits and services. And also, we're really hoping to see gap coverage when people change health plans so that providers continue to be funded for the services that they're determined they're going to continue to provide. Jeanette, did you have anything you wanted to add to that?
Yeah, I think you covered most of it. The only thing that I would just really emphasize is the constraints and the once in a lifetime limits on tenancy sustaining services. And what we see then is an ongoing need for services, and really the demonstration of how it's really linked to housing stability once somebody's moved into a unit.
Yeah, that's a great point. And the same is true for the housing deposits. Both things that if we can't get them into sustainable housing, that they're going to need again at a future date.
Thanks so much, Glenn and Jeanette. And to reiterate points that you and Cheryl have made earlier, we know people cannot get well or stay well until they're housed. And so the most important role of housing support services is to help people gain access to housing, and then that they can afford, and then help them remain stably housed. Funding housing support services is an important part of the solution, but not the entire solution, and so cannot operate siloed from our homeless response and housing systems and resources. We know that adequate services funding is critical to the success of any supportive housing project that we build with state money. A housing support services benefit, as Linda discussed in Solution 1, provides an opportunity to base eligibility for housing on eligibility for these services. With a benefit, our health agency can work with our housing agency and department to ensure eligibility for state-funded housing is based on eligibility for a Medi-Cal benefit that's funding housing support services. Policymakers could create guidelines that ensure that service providers that work closely with developers on creating housing connect people to the benefit, to a housing support services benefit, and then help people with reauthorizations to stay on that benefit or receiving the support services for as long as they need those supports. And both our housing and health departments should ensure that as long as tenants need the services, they would be able to receive the services in housing units built with or funded by state funds. Linking housing to eligibility for a benefit could help supportive housing projects scale up funding for services and allow projects to move forward more quickly. We do see that one of the biggest barriers to creating more supportive housing with the capital funding that the state now provides is lack of services funding and just the delay that it causes to pull the puzzle pieces together, as Glenn described, multiple different sources of funding, funding services, and sometimes not paying adequate rates to fund those services. The Department of Healthcare Services can work also with the California Interagency Council on Homelessness staff to educate local homeless response systems, housing providers, and developers on both CalAIM funded services and eventually a housing support services benefit, and seek input from these stakeholders on the design of a future benefit. So I'll turn it over to Cheryl.
Great. We are now going to open things up for Q&A. Please use the Q&A comment box at the bottom of your screen to submit questions, and we will do our best to answer those live. Any of the panelists are welcome to answer questions. And I first want to ask Sharon, are there any questions that came in throughout the presentation that we have not gotten to answer that we'd like to?
I don't see any that we haven't answered in the Q&A box. I think there might be a few in the chat box.
Okay. All right. We did have a couple questions about the recording. And I did want to clarify that this is being recorded, and the California Healthcare Foundation will be sure to put the recording on their webpage next to where the publication link is living right now. So I think it was John that asked, will CSH have this on our website? We'll make sure that it's on the California Healthcare Foundation website so that it's publicly available to anyone after this. Janai, I want to turn it to you. I think there was a question you wanted to answer.
Thank you. Someone asked, I was wondering if you had a sample of data sharing agreement that allows MCPs to become utilizers of the data repositories that are being used by homeless service providers, such as HMIS. And I did write, it just didn't go out to everyone accidentally there, that the data sharing agreements are different by county or region. I don't have an example because it's specific to our county. I don't know what county you're in, but they are generated in this case, excuse my answer, but in this case, if you want to become part of the homeless management information system, they are normally generated by the office that takes care of homelessness. In our case, it's the Office of Homeless Services that's in charge of the homeless management information system. In different counties, different county departments take care of that, but you just want to find out who's in charge of your homeless management information system. And it is not hard in our county to become a part of that system. In our county, it takes an email, and you want an agreement. You just request an agreement to become part of the homeless management information system as a homeless provider. And they'll in our county, they send you out a application, and you fill it out. And in the application, it asks what services are you providing, and it asks a little bit about who you are and when you started, and, just some preliminary information. And then you go through a training. And from there, after the training, to learn how to navigate the, the technicalities of the system, then you are, excuse me, you are free to start entering data into the system. As simple as that. We added the organization that I work with, we added a component, and we called it, the name of our MCP, because we have specific clients that we're getting through our authorization portal, and we want to make sure that we put them into our information management system. And so every time we get someone in the portal, they are automatically put into that system. So now if our MCP joins us, which we do expect eventually, that we will be linked together, and they will be able to see all of those people that they refer to us, and that they're referring to other homeless providers. So simple as an email. Start with an email, and then you'll be guided.
Janai, there was also a question about sharing the Exhibit E form that you mentioned during the webinar.
Okay. While we're on here, I will try to find the link in it at the HUD site, but I don't know what it normally is called. We just say Exhibit E, but I will try to find it and then put a link in the chat box.
Thank you.
Other questions?
We have a lot of questions in the chat, and it seems like presenters did respond with answers to a lot of those questions.
Okay, well, I'll give it one more minute in case anyone has others.
I think there was one question that may have gone unanswered. I have a patient that was in a program that was paying for his room, and now he was told the program ended. Are there any options? Does anybody have a response to that question?
It's a fairly complicated response, but I'm happy to step into it. So because CalAIM doesn't provide rental assistance, CalAIM itself is not going to be the answer to that question. However, with housing navigation or tenancy supports, depending on the location of the individual, the CalAIM service case managers often will work with the local resources available to help identify funding sources that might be able to provide that assistance. The challenge is that is coming from a lot of different places, and it'll depend on the specific eligibility of that person, whether they are a veteran, whether they qualify, whether they get matched through CES or anything like that. So a lot of different possibilities, but it is really going to be a more regional response based on the needs of and eligibility of that person.
Thank you, Glenn. I noticed a couple of different chats that came in. Let's see, looks like those got answered as well. There is also reference to some of the other CHCF documents that have been about CalAIM. California Healthcare Foundation has done quite a bit of work around making CalAIM, successful. And so it's worth checking out the resources that were linked in the chat. And that wraps up our webinar. I want to thank everybody for joining today and doing such a good job participating with questions. Particularly like to give a special thank you to our presenters, not only presenting the information very clearly, but also being so on top of answering people's questions in the chat and Q&A. I would encourage everybody to read the full policy brief on the CHCF website under their publications page. And with that, I hope everybody has a wonderful weekend and appreciate you joining. Thank you very much, everybody.
Thank you.
Thank you.
Thank you, everyone. Have a great weekend. Great job, team.
Thank you. Great job, everybody.